Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on mentors and motivators who are consistently reshaping, redefining, and rediscovering the field of medical healthcare. I would like to welcome Dr. Jack Monaco, founder of the Monaco Center for Health and Healing. He practiced obstetrics and gynecology until 2007, when a personal health crisis changed his trajectory. He is fellowship trained and board certified in anti-aging, functional, and regenerative medicine. He is an oral board examiner for A4M and a sought-out lecturer throughout the United States. Good morning, Dr. Monaco. Thank you so much for joining us today.
Good morning. My pleasure.
So we're going to just sit and talk really about your journey as a physician and what initially inspired you to go into medicine and whatnot. So why don't we start back to when you were a child? Did you have any interest in the sciences at that time?
No. I wanted to be a cop just like everybody else in my generation, or a cowboy or a fireman. And something happened that changed my life, and my sister got sick. And I was 11 years old, and she died when she was 18. And I had just started studying science, and I was fascinated by science. So my original quest for medicine was to find a cure for cancer. She had acute lymphocytic leukemia. I actually wanted to be a musician. So after the cowboys and the policemen and the firemen, it was like, I'm going to be a musician, because I started playing guitar when I was 6. But I realized that I would not be a very good musician. I would be one of those starving musicians. So I had a different calling, and it turned out to be a good thing. So I went to medical school, and obviously I didn't find a cure for cancer. My calling was in a different direction, so I went into obstetrics and gynecology. And I think part of the reason I did that was because experiencing death at a very early age, it's not normal for an 11-year-old child to think about their own mortality. So I went into a very happy field, bringing life into the world rather than watching life leave. And it was a very rewarding but stressful career. So it was really the stress that got me out of obstetrics and gynecology into anti-aging and functional medicine.
What was the initial motivation besides the stress?
I got sick. I got very sick. And I got so sick that I had to give up my obstetrical practice. And all my conventional colleagues wanted to do was either give me drugs, or I had ulcerative colitis, or they wanted to take out my colon. And I said, no, that's not in my game plan. And something, again, happened to change my life. I got a call from a fellow named Victor from the American Academy of Anti-Aging Medicine. This is back in 2005, okay? And I had become a member of the American Academy of Anti-Aging Medicine through a company called Market America. I was a speaker for them, and it was a network marketing company. And I thought, this is great, because now we have all these different nutraceuticals that I can use for my patients, instead of, you know, the stuff that you might find in the Sam's Club or CVS or one of those places. That's really not very good. So Victor called me, and I was really sick, and I told him I wasn't going to go to Chicago. And he convinced me to go, and I signed up for the fellowship that day, and I never looked back. So I gave up obstetrics in 2003, started my fellowship in 2005, got my board certification in 2007, and then opened up a wellness center in Connecticut in February of 2008.
And when did you get better?
About 3 months after I went to my first module.
Amazing.
Yeah.
Amazing.
So I learned enough, and somebody took me under their wing. So I was able to start working on myself. I didn't really get completely better until just about a year or two ago. So it's been a very, very long journey. What I've learned from my own health issues has really helped me to help other people. So it's really been, like our pastor used to say, it's a eucatastrophe. Okay, something that happens that's terrible turns out to be good. So this was something that was terrible for me, but it turned out to be good for everybody else. So it was a good thing. I don't regret it.
So it took all this time to get yourself better. What changes did you make? Was it diet modification, or?
I started the diet modifications and the medical foods and all those types of things, and I symptomatically was better, but I always had that chronic underlying inflammation that I could not get rid of. I just couldn't get on top of it. And then in the process of doing what I do when I moved to Nashville 3 years ago, I started seeing more and more patients with autoimmune disease. So rather than doing just hormones, I started getting more patients with Hashimoto's and autoimmunity. And I met a nurse when I first got to Nashville who told me about low-dose naltrexone. I'd never heard of it. So I started researching it and come to find out this is probably the closest thing to a miracle drug in the 21st century that I found. So I started taking LDN myself. I've been on LDN now for 3 years. And for the first time in 25 years, when I had a colonoscopy, there's absolutely no inflammation. It's all gone. Not in my just, the mucosa is better and symptomatically better, but the underlying inflammation, that's the real killer, that's gone too. So I use a lot of low-dose naltrexone in my practice.
That's incredible.
Yeah.
Well, I'm so thrilled for you and for your patients as well. So I noticed when doing some research on you that you actually got your BA in zoology. Mm-hmm. So how did that come to be?
Well, I went to a small liberal arts college in New Jersey. I grew up in Jersey. And
what exit?
At West 163.
Okay, 131.
Okay. So my wife's a Jersey girl too. So I went to a small liberal arts college in Madison, New Jersey called Drew University. And Drew was so small that they didn't have a biology major. They had separate botany and zoology. So zoology really is biology without the plants. So they had their own separate botany department. So I was actually a zoo major, one of 6 zoo majors to graduate. That's how small this school was. And it turns out that when I went to medical school, the director of admissions also went to Drew University. So he knew about it. He knew how good a school it was. And so when I was accepted, I was actually called down to his office when I was accepted because I did a year of cardiovascular research before I went to medical school. So he called me down to his office and said, I know all this about Drew and I know how good a school it is and all this. And he said, I've decided to accept you. So that was like the greatest moment of my life was getting accepted to medical school. And it was just a small little school in New Jersey that did it.
That's incredible. So what brought you to Nashville?
Mark Houston. I was, when I did my fellowship, Mark lectured. It's the first time I met Mark, and he lectured on the cardiovascular system and dyslipidemia, cholesterol, and it was like a real eye-opener. It was like the best description of cholesterol and endothelial dysfunction I ever heard. And then Mark and I just kind of lost touch with each other. I went my way. He was down in Nashville. I was in Connecticut. And one day I was in line at the area hotel. I was signing up for the one of the advanced modules for my master's. And Mark walked over. We started talking. So Mark, like me, always wants to sit in the front row. So I'm always down there early in the morning. I want to be in the front row. So Mark and I sat next to each other during all these courses. We actually took a couple of courses together and got to know each other. And then I took his cardiovascular module, the advanced cardiovascular module. And I really learned a lot from him. So he asked me, he said, would you consider coming to Nashville? And I said, why? And he said, there's nobody down there that can do hormones. He said, I'm doing hormones for my patients, but I really don't want to. So he said, we need somebody down there that knows how to do hormones. So I was looking for a change. So again, it was just it was a perfect storm. Everything just kind of fell into place. So now Mark and I work together in the Hypertension Institute. Even though I'm an independent practitioner, I have the Nashville Hormone Integrative Medicine Center. Mark has the Hypertension Institute, which is more of his research-based practice. But we're all practicing. I walk out of my door and I walk into his door, and we're that close. So I see all his hormone patients, and he sees a lot of my cardiovascular patients. So it's a good setup, and Mark's helped me a lot. He really has.
And how long has that marriage been?
I started officially with St. Thomas Medical Group in January of 2015. I moved down to Nashville in August of 2014, and got settled, and I still maintain a Connecticut practice, so I still do phone consultations with my certain Connecticut patients. But I'm seeing most of my patients are going to be in the Southeast now. Although we have some people that come from a distance, just like they do for Mark. So it's nice, to have that kind of following. And like everybody in medicine knows, the best referral source for your practice is other patients, is happy patients. So we get most of my referrals are coming from other patients because doctors still don't understand what I do. And that's been the hardest thing to overcome, is to brand myself, is to get other people to understand what functional medicine is. You know, what do we do that's different? You know, we're not passing out supplements in our kitchen. You know, we're not doing crazy things. We're not burning incense and laying hands on. Although laying hands on is important. You know, touching patients is important. But we're not doing all the crazy things that other physicians think we do. We have a lot of literature that supports what we do. I mean, when I lecture for MMI, everything that I say has to be documented in the literature. So there's literature that supports what we do. It's just getting other physicians to understand that. And I think that's where A4M really comes in, because when people come here, it's a life-changing experience. It changed my life. So it's been one of the greatest things educationally that's happened to me.
So how did you initially implement this into your practice?
That's a great question. I went to a module, and I'm still doing OB-GYN, but I'm not doing obstetrics anymore. I gave that up. But I'm just doing office-based GYN and surgery. And I would go to a module, and then I would come back and I would review what I had learned, and I would start to implement that in my practice. So I would have my staff schedule hormone consults, just specific hormone consults. And whatever the insurance paid, it was fine with me. I was learning. And I started learning about compounding and how, to adjust hormones to give the best result with the least amount of problem. So every time I came back from a module, I learned something, and I started implementing that into my practice. So by the time I was ready to retire from GYN and start doing functional medicine full time, I hit the ground running. I mean, I already had a following, and I already had my way of doing things. I had my compounding pharmacies. I knew what my doses were, and but I'm still learning. You know, it's been 10 years now, and I'm still, every day I learn something new.
Other than your personal health, how else has it impacted your personal life?
I think it's made me a better physician, because having experienced the pain and suffering that goes along with inflammatory bowel disease, it really does make you much more empathetic and understanding about patients. You know, it was always frustrating for me as an obstetrician gynecologist. I could never say to a woman, I know what you're experiencing, because I never had a baby, and I never will have a baby, and I've never had menstrual cramps. I've never gone through those things. I can only say, I can only imagine how you're feeling. But now I can look somebody in the eye and say, I know exactly how you feel. You know, when somebody tells me that they've got severe ulcerative colitis and they've had their colon removed and they're still not better, and one fellow came into my office, and he's a very, very well-known Christian rock star, and he sitting in my office, I'm talking to his wife and his son. I'm actually taking care of his son, and he's hooking himself up and giving himself infusions, and I said to him, I can help you. I know what you're feeling. So we're going to work together and see if we can't get him fixed. But he had a total colectomy, which is really sad. You know, we can avoid a lot of those things in many cases. Not all cases, but in many cases we can, if we just address it the right way.
You had mentioned that you just went back to your office and you quit obstetrics and you gave up that part of your practice. Was there ever a time that you felt like you wanted to give up medicine altogether?
Oh, yeah. I was working with this network marketing company, and I was so frustrated with the stress of my practice, the toll that it was taking on my family and my personal life. I said, there's got to be a better way to do something, to maintain our lifestyle, which was not extravagant. I mean, we were very blessed. We had a nice lifestyle, but we didn't have the biggest house in the neighborhood. In fact, we probably didn't have the biggest house in the town. But the point is, we were comfortable, okay? And but it was taking a tremendous toll. So I looked at this as a way of keeping my hand in science, but also helping other people become successful and getting out of the stress of night call, carrying a beeper. Most everybody that's going to view this has heard of Pavlov's dogs. Okay, that beeper for me was a Pavlovian response. When that beeper went off, my blood pressure went up, my heart rate went up, I could feel my cortisol rising, and it was one of the most stressful things in my life every time that beeper went off.
I'm sure your wife and kids probably felt the same way.
Oh yeah, I slept on a couch many, many nights so that they wouldn't wake up when the phone rang or when the beeper went off. And yet when we were medical students, it was a big thrill to carry a beeper. We were important. We were real doctors now because we had a beeper. But that beeper became such a stress for me that I swore that I would do something where I never had to carry a beeper again. So when I quit obstetrics, I threw away my beeper because I didn't need it anymore. I was now office-based practice, and I was doing surgery 1 day a week. My staff knew where to reach me. I had my cell phone. I didn't need a beeper. So I got rid of that stress. But it took me 6 months every time the phone rang before I would get that stress response to calm down. 6 months. But being an obstetrician for 30 years, can't expect it to fix itself overnight,
So when you were in medical school and you were learning everything that you were learning then, and then you started in the fellowship program here at A4M, and you started to learn, or should I say relearn, everything that you had already been taught or should have been taught. Mm-hmm. How did you wrap your arms around that, saying, I never learned about nutrition, I never learned about any of this and what the effects are on your body?
Yeah, medical school was probably the best 4 years of my life. I loved medical school. I was where I wanted to be. And I never ever imagined that I would do anything else but obstetrics and gynecology. I never imagined that I would lecture on a national level. I never imagined that I would do anything else outside of the operating room. I thought, I'm going to die in the operating room, okay? Or I'm going to die pretty close to the operating room because I just love surgery.
You probably would have had you not gone out.
Well, that's true. But all of a sudden something changed. I started looking at things, and I was always frustrated when I did everything that I was taught to do for a patient and they didn't get better. And that always frustrated me, and I started to think of surgery rather than being the cure. Surgery is the last resort. It's a failure. We can't fix things without surgery. Now, there are some cases where you need surgery. I'm not saying that. What I do now is not acute care medicine. It's chronic medicine. So you still need the acute care side of medicine. So if somebody's in an auto accident, they're not going to come into my office for hormones, okay, or for their thyroid. They're going to go to the conventional route to get fixed. But with chronic diseases, that's where we're missing the mark. So I had to readjust my thinking a little bit. Do I miss the operating room? Yeah, I do. I was known for doing laparoscopic surgery. And I've gone on medical missions, so I've gotten a chance to do some surgery after I retired. Actually, that's where I met my wife, was on a medical mission. But I'm not doing laparoscopic surgery. It's all abdominal surgery. But still, I got my hand back in surgery a little bit. So I can go back on a mission anytime and still operate if I want to. But right now, what I do is so fulfilling. It's so rewarding. When patients come in and say, I feel better than I've ever felt before. And that's just the best thing in the world for me, is when they come in and they say that, it's like, okay, I'm doing something good here, So I don't miss it. I don't miss the stress. I had a good career. I have those good memories.
Can you share a patient success story that sticks out?
Probably the funniest success story that I have a lot of them, but this guy stands out. Now, here is an obstetrician gynecologist starting to take care of men. Okay, that was more stressful than doing obstetrics, because I've been taking care of women for 30, 35 years. Now all of a sudden I'm going to start talking to men about some things, and it's like, no, this is not how I was brought up. Okay, but nevertheless, he walks in. He's a retired police officer from California. He and his wife are both retired police officers, and this guy is a bodybuilder. So he is ginormous. Okay, he's about 280 pounds, and he is built like a you-know-what. Okay. And he's in and he's on high doses of topical testosterone, like 200 milligrams a day, and he's doing all this other stuff, and he won't listen to me. I told him, I said, this is not good for you. And he said, well, doc, I feel good. I said, but it's not healthy for you. And what finally convinced him, when he came in with his wife one day, and he said, my wife is not doing well. I said, what's the matter? He said, she's not feeling well. She's aggressive. She's angry. She's just not herself. So I asked him, I said, how do you put on your testosterone? So he told me. And I said, you're contaminating your wife. And he did not want to do a saliva test because he didn't want to spend the money. And I said to him, I'll pay for it. Just do the saliva test. So I did a saliva test on his wife. And the normal range for a woman for testosterone is 16 to 55 picograms per ml. Her level was 6,500. Okay, and that convinced him that, okay, this guy knows what he's talking about, let's go down that road. So I had to wean him down because he was on a huge dose of testosterone. And I finally switched him over to a compounded injectable. And one day he walks into my office, and I always dreaded when he walked into my office because I knew it was going to be a fight. Not a fight, but a discussion. There was going to be some pushback from him, and I just didn't have the desire to get into it with him. So he came into my office, and he said, "Close the door." And I said, "I don't know if I want to close the door. I want to keep it open in case I have to get out of here fast." He said, "No, just close the door." I said, "Okay." And he says, "Come here." I said, "What?" He said, "Give me a hug." Oh. And this guy gave me a bear hug, and he said, "Doc," he said, "I feel better than I've ever felt before." So I tell that story in my testosterone talk because you have to be patient with people. You have to kind of guide them through the changes, especially when they know as much as he did being a bodybuilder. A lot of bodybuilders manipulate hormones and they do a lot of crazy things, but they understand their bodies better than most people. So it takes a lot of time and patience sometimes to get these people to understand that it's not safe. What they're doing is not safe. So now his wife is normal, her salivary testosterone is normal, and they're as happy as can be.
So who is your typical patient that comes to see you now?
Typical patient is a woman between the ages of 35 and 55 or 60 who is either perimenopausal, having a lot of symptoms, anxiety, depression, not just hot flashes, but all these other things, difficulty sleeping, their marriage is struggling, they're not feeling well. And a lot of times they're fearful of taking hormones because those hormones cause cancer. And that's what they believe, that's what they're told. And their friends say, just go get checked. So they come in and we talk about it. I have to spend a lot of time talking to people about hormones because they have a lot of preconceived notions. Plus they're hearing things from their doctors, like progesterone causes breast cancer. Well, that's not true. And then I talk to them about the literature that shows that progesterone actually protects the breasts. So the time for a woman to start looking at her hormones is really in her mid-30s. That's when you start to see these changes, and that's when you start to see the significant rise in the slope of the curve for breast cancer. Most breast cancers are diagnosed postmenopausally, but during that 15 or 35 to 50 age group, those 15 years is when you see a tremendous rise in that premenopausal breast cancer. So we have an opportunity with hormones not only to make their lives better, but to do some preventative medicine. So that takes time to explain to people. But,
and how much time do you spend with each patient?
Initial consultations are between 40 and 60 minutes. You know, their follow-ups, the initial follow-up is usually 30 to 40 minutes, and then once they get organized and once we get them balanced, I can usually do a follow-up in less time than that, 20 minutes. But they ask a lot of questions, and you can't just say, oh, that's next time. So you answer the questions. So my patients know that I usually run behind, and if I do run behind, it's because I'm talking to somebody. So I'll give them the same time too. But I can't see that many patients. I used to see 30, 40, sometimes more patients when I was doing OB-GYN. Now if I see, my average day is 12 to 14 patients. When I go back on next week, I have 21 patients scheduled, and I don't know how I'm going to get through today. I just don't know, because I start at 6:20 in the morning, you know, and I've had to expand my hours, so I'm putting in 12-hour days right now. But that's okay, you know. I'm enjoying it. I like what I do. I can't complain.
What's the most rewarding part?
I go out at the end of the day and I say, you know something, I've made a difference in somebody's life today. I can look in the mirror and say, you did a good job. You know, I didn't hurt anybody that I know of, and I may have helped them. So it's just knowing that when you go out that I'm doing something that is making a difference for somebody.
So if you weren't a physician and a police officer or a fireman or a cowboy, what do you think you would be doing?
I'd probably be a cop. I've just always had this fascination with law enforcement. One of my biggest regrets is that I didn't serve my country. You know, I was so busy with education, and I had a 2S when I went to college during the Vietnam era. Okay, don't do the math in your head. If you want to know how old I am, I'll tell you. But so I got a 2S, and then I went to medical school, and after that, it was, you know, you're on a track to practice and study and get your degrees and all that, and your training. But that's my biggest regret. And my son is actually, he just decided to join the Air Force. He's 32. So I'm excited about that. He's finally got some direction, and so he's leaving in 2 months for his basic training in Texas. So I'm excited about that. So maybe he'll be the one, not me, to serve his country. But yeah, it's probably what I do.
So what advice would you give to a physician who is considering transitioning to functional or integrative medicine? Or one that's just completing a fellowship?
I think probably the greatest temptation that we have is doing things because it's revenue generating in the practice, okay? And I've always believed that if I do the right thing, God will take care of me. I'll have what I need. I don't have to worry about, am I going to be able to feed my family? Am I going to have a roof over my head? I've been very fortunate, okay? So I don't do anything in my practice just because it may be more lucrative, even though it's perfectly acceptable. Okay, there are some things that I don't do. They're great revenue generators, but I don't believe in them, so I don't do them. Not that it's wrong to do them. It's just not what I do. So I would tell people, you have your own beliefs. As they told us in medical school, treat your patients the way you would want your family to be treated. So I wouldn't want to do those things on myself, so I'm not going to do them on my patients. But there are a lot of things that you can do. It's a very rewarding path if you do it the right way. And I tell you, coming to these talks and to these seminars that we do and the symposia and all that, and talking to colleagues, I've developed many, many, many wonderful medical friendships. When I was an OB-GYN, I wanted nothing to do with medicine outside the office. I didn't go to country clubs, I didn't go to cocktail parties. I had very few friends that were doctors that I rubbed elbows with. My dad was a plumber, so I rubbed elbows with the blue-collar guys, okay? And that streak is still in me, okay? But I will tell you that I have so many good friends from having been through the fellowship and now being a board examiner and lecturing. It's really very, very rewarding. It's very satisfying.
Is there anybody that you seek mentorship from?
Well, I have a lot of people that have helped me along the way. Of course, Mark Houston, Pam, was the first person that I met when I came to my fellowship to do hormones. Jim Paoletti is a pharmacist. Jim and I went through the fellowship together. Jim and I used to do traveling seminars together. So it was really kind of cool because he would talk about compounding and bioidentical hormones and receptors and things like that. And then I would come in as the physician and show the doctors in the audience how you implemented what Jim talked about. This is how you do it in practice. So Jim has been very, very instrumental. So is David Zava. He was first lecture that I ever gave on a national forum was for David Zava and ZRT. And there are many others. Lena Edwards is a dear friend of mine, and she knows more about the adrenals, I think, than anybody but God. And so she's taught me a lot about the adrenals. So I have a very select group of people that I really respect their opinion, and I seek out their advice if I need it.
So in your talk this afternoon, how do you hope to inspire the constituents that are there listening? I'm probably going to be speaking mostly to cardiologists, so they may not do what I do, but I want them to understand that there's a difference between hormones and hormones. They're not all created equal, okay? And I've heard that so many times from physicians. Oh, all hormones are the same. And I usually tell them, okay, if that's the case, I'm going to buy you a brand new Volkswagen. I want you to buy me a brand new Bentley, and we're going to trade because all cars are the same. So that's never happened, of course. But the point is that doctors are not taught the difference between these different hormones. We're taught in gynecology school that if a woman's had a hysterectomy, there's no reason to take progesterone because the only reason to take progesterone is to protect the endometrium, and that's not true. Progesterone balances all the different functions of estrogen. We're finding that there's estrogen receptors, modulators in the GI tract, and just everywhere. So getting the hormones properly balanced is important, and that takes training. I see too many doctors that are out there, oh, I do bioidentical hormones. Okay, well, bioidentical hormones has become a buzzword.
Okay, and patients focus on natural versus synthetic. Natural is good, synthetic is bad. Really what they need to learn is that bioidentical hormone, call it whatever you want, human identical, it's not similar, it's not close, this is not horseshoes and hand grenades. Okay, this is a precise science, relatively speaking. So that hormone has to fit into the receptor. So all this stuff that we talk about doesn't mean anything if that hormone doesn't get to the receptor. So you have to know about receptor response, you have to know about something called tachyphylaxis, which is receptor downregulation and overload. I mean, there's so many things that a physician needs to know. You're not going to pick it up from a textbook necessarily. You get it from coming to these talks, to these lectures, and that's where this stuff comes out. So when I talk to the group today, I want them to understand that not all hormones are bad, that hormones have a place, especially in cardiovascular disease. And when you look at the literature, I'm not making this stuff up. I didn't think about this. I didn't have this in a dream, okay? When you look at the literature on cardiovascular disease and hormones, you see that there is a place for hormones. But there's also a downside, and that's not what we're taught. We're taught that you can give hormones anytime after menopause. At least that's what I was taught. Now, I'm going back many, many years. Maybe the new generation that's coming through OB-GYN residency is being taught something different. But when I was taught, you can give a hormone to a woman anytime after menopause and get all the same benefits with no downside risk, and that's not true. And that's what we'll talk about today.
And how do you hope that these cardiologists go back to their practice Monday morning and start implementing what they've learned?
I hope that they'll see the connection between cardiovascular disease and hormones. Okay, I always screen patients, usually verbally, about cardiovascular disease, and if there's something there, then they get referred so that they can get worked up. Same thing the other way around. Somebody comes in and they've got some heart problems, you got to start thinking about hormones because there may be some benefit that you can get from hormones. So those two specialties have a commonality when it comes to cardiovascular disease. So that's what I'm hoping they'll take away, that they'll say, you know something, I just heard a talk about this, and I think maybe you need to see, this doctor about your hormones. And there's fellowship-trained, board-certified people just about everywhere in the country. And I tell my patients, call A4M, find out who's closest to you that's board-certified and fellowship-trained.
So you've been practicing this type of medicine for 15 years?
Well, I started my fellowship in 12 years,
okay.
But I started doing bioidentical hormones back in the 90s. Okay, I was one of those people that thought they knew what they were doing, but didn't. So a patient came into my office. That's how I got started in bioidentical hormones. She came in, and I was interviewing her, and she said, I said, what medications are you taking? She said, well, I take bioidentical hormones. And I said, bio what hormones? She said, bioidentical hormones. She said, well, what do you use? I said, well, I use the conventional hormones. She said, well, how do you know how much to give? I said, well, we give it to make the symptoms go away. And I said, the literature has told us what the doses are. So I said, what do you do? She said, well, I do a saliva test. I said, excuse me? She said, I do a saliva test. I said, you spit in a tube? She said, yep. I said, I've never heard of such a thing. She reached down into her bag and she pulled out a stack of articles this big, and she literally threw it on my desk, and she pointed her finger in my face and she said, you need to read this. I said, okay. And I went home and I read it. It was fascinating. I called her up and I said, I don't know how you got onto this stuff, but this is really cool. So I sought out a compounding pharmacist, and that's how I started doing hormones. But I still had no idea what I was doing. I was converting my oral doses into topical doses. I had no idea about absorption, no idea about any of this stuff. But I was doing what I thought was right. So I know that oral hormones are not as good as topical hormones, but you can overdose somebody on topical hormones. So as I started going through my fellowship, my doses got lower and lower and lower and lower. And now today, my average dose is very, very low. You don't need a lot of hormone to get the benefits.
So you've seen the growth of the industry in both bioidenticals as well as the acceptance of functional medicine.
Yep.
So how would you personally describe integrative or functional medicine?
Functional medicine is asking the question, why? Why does somebody have the problem that they have? So we were taught in medical school that the symptoms equal a diagnosis equals a drug. In functional medicine, the symptom tells us where the problem is, and then you address the problem, and the symptom should go away. If the symptom doesn't go away, there's something else going on. I use the example of a person driving down the highway and their oil light comes on. They got two choices. They go to the mechanic, he traces the problem, fixes it, and the oil light goes out. Or they lift the hood up and cut the wire to the oil light. Okay, either way, the light's going to go out. So the drug really just masks the symptom. The symptoms really tell us where the problem is. Now, we also integrate other modalities. It's not just drugs. We're using nutraceuticals, we're using other modalities, acupuncture, massage, stress reduction, and things like that. So it's a little bit more of an out-of-the-box thinking, but we still apply conventional medical principles. So, as I say, allopathic Western medicine, great for acute problems, not so for chronic disease. So we're really helping people with those chronic problems. We're trying to prevent cardiovascular disease early on instead of treating it. So it's a little bit different approach, but we still use conventional medical principles.
And do you implement nutritional modification therapies in your practice as well?
Absolutely.
So
there are some states that forbid a doctor from talking to a patient about nutrition because he's not a dietitian or a nutritionist, unless you have a degree in nutrition, which a lot of doctors do. But I work with a nutritionist in Nashville, and Dr. Houston, we have a nutritionist or a dietitian that works with our patients too. So they educate people about the foods that they eat. The difference, I think, between a nutritionist and a dietitian is the nutritionist teaches people how to eat for health, where the dietitian is focused on carbohydrates, fats, proteins, and calories and weight reduction. So I like to work with nutritionists because I think they have a different approach, a little bit different way of counseling. It fits in with what I do.
What's your take on gluten?
It's a big problem. It's becoming a bigger problem. I see so many patients. As I said, my practice has morphed into a lot of Hashimoto patients and autoimmune patients. So having an autoimmune disease myself, I was very interested in what's going on. So I ventured into that arena, and gluten is huge. It's huge. But what I found, which is really interesting, we tend to think of certain foods as being gluten-containing. But there are foods that you don't think of as gluten that can give you the same reaction as gluten. For instance, things like tapioca and quinoa and amaranth and yellow corn and white potatoes. So we test patients for those cross-reactive foods. A lot of gluten-free foods are using tapioca as a filler. So now you've got somebody who is sensitive to gluten, they're gluten-free, they're going through the expense, they're going through the difficulty of being gluten-free, and they're eating something that has tapioca in it that's giving them the same reaction. So you have to identify those people, identify what they're sensitive to, remove that from their diet. We use things like fish oils, and there's some specialized fish oils that are available, some gluten digesting type of nutrients that help people if they're exposed to gluten. And then we use medical foods to heal their gut and probiotics. So there's a nice functional approach to the gut. And by the way, that is just very, very elementary treatment of the gut. It's getting to be much more sophisticated than that. But that's just a basic approach to the gut.
So can we go back and talk about your sister?
Mm-hmm.
Okay.
Sure.
So what do you think she would say about the journey that you've had?
I don't know. She'd probably say you're doing a good thing. I still struggle with the question, why did I get so many years and she got so few? Is it simply to give me the opportunity to do this? I probably would have had a little bit gentle nudging to do this. I didn't need something so drastic. But there's a reason, and I don't know what that is. But I think she would probably say, you're doing a good job. 'Cause I like to think that I am.
Well, it sounds to me that you've helped an awful lot of people. So.
I'm trying. Yep.
Is there anything that you would have done differently along the way?
I don't know. No, I think the career that I had in OB-GYN was an important stepping stone. I wish I had gotten into this medicine earlier. I was in my 50s when I started doing this, so I wish I had
Those
recognized
hormones are really
this.
working for you.
Well, I wish I had recognized this. When I was in Connecticut, I actually have an appointment at the University of New England College of Osteopathic Medicine and Family Medicine. And we were trying to set up a fellowship or a residency, not a fellowship, but a residency in functional medicine for the medical students and the residents from NEOG, New England College of Osteopathic Medicine. And it was very interesting to see the response that we got. Some students and residents were totally disinterested, some were on fire, and some were negative. And I tried to encourage them, early in your training, start to think differently. Just start asking those questions. You're not going to necessarily change what you're being taught. I'm not asking you to do that. I'm just saying, start to think about things. When something doesn't make sense to you, don't just do something because it's a protocol or because your resident told you to do it. Start asking those questions. Think about what you're doing, and maybe there's something else that particular patient needs. Like my friend says, the mind is like a parachute. It only works when it's open. So if you don't have an open mind to this stuff, you're going to just go down the same old path of allopathic medicine, and patients are going to come in. And some patients want this. Some patients, they say, I don't want to do any of that stuff. All I want is a prescription. Unfortunately, they're still out there because what we do does take patient compliance and patient desire. So if the patient's not on board with this, it doesn't work. So the patient really has to be on board with it, but they have to have a doctor that can explain that to them and guide them through the process. That's what I would tell people.
Thank you so much for your time today.
You're very welcome. Thank you for having me.